Thanks, Dale, for the kind introduction, also for organizing this event. Been a pleasure really to see the amount of people that showed up this evening and who are interested in chronic myofascial pain, apparently. I'm going to hopefully give you some new scientific insights and potential new therapies for challenging clinical thing that we see, probably a lot of us in our general practice, but also in our practices with working with high performance athletes or even people who are dealing with work-related injuries. And we have a nice mixture of, I think tonight, of GPs, sport physicians, soft tissue therapists, physiotherapists, and some other disciplines that I might have forgotten. So I hope we can get also in the panel discussion, interesting discussion on how everyone looks at this clinical problem and how they can contribute in solving it, because I think it's quite challenging to deal with. Now, I moved 2.5 years ago in private practice, started at Oker Health in Bruce, and moved and also working now in Kingston, so sort of spread across the lake. It's an interesting sort of combination of practice because you have different kind of demographics. But I recently also joined 2 half-days a week practice in Toggenang in Greenway. It's called Lakeview Medical Practice. So also basically offers a service to the more southern inhabitants of Canberra, because some people really have difficulty crossing the lake, I learned. So what I'm going to talk about is actually the role of connective tissue and fascia in acute and chronic musculoskeletal overuse injuries, the role of nerve entrapment as a cause of chronic myofascial pain syndrome, and some of the different injection therapies that have been used as an adjunct treatment for this problem. So I'm not sure how you've been trained as a medical doctor or clinician or physiotherapist or soft tissue therapist, but when I did my training in medicine, there was actually no interest in fascia whatsoever. Basically, there was when you did your an anatomical training, basically you got this cadaver, and cut through the skin, and you see this white layer, and it's dry and it's hard and it's difficult to cut through it, and you're really happy that once you remove the layer, because then you see the interesting stuff, which is the muscles and the tendons and etc., and the big and the large nerves. And what this fascia is for is basically not addressed. I went to this 2009 to this fascia research conference in Amsterdam, and that was really for me an eye-opener. And I think it helped me really in improving my understanding of what the role of fascia could be as connective tissue, and also what sort of clinical problems you can see if you once you actually get an eye for it. So there's a group in Italy led by Professor Carla Stecco, who does a lot of research on fascia. What they actually have done is actually they started looking at anatomy and the fascia in fresh cadavers, basically people who just passed away, who haven't been put in formaldehyde for 9 months. And that already gives you that's actually pictured on the left. So they actually published a couple of interesting books, an anatomy atlases, basically, where they describe the fascial structures in the human body. So this is, as you can see, looks a bit different from what you and I were taught when we did our anatomy training in med school. But actually, there's not a lot of fluid here anymore, because this is probably 24 hours after people die. But at this fascia research conference, there was also a video presented by Dr. Jean-Claude de Guimberteau, who is actually a reconstructive hand surgeon from Bordeaux, France. And actually, he was interested in what caused adhesions after tendon transfers, and because that means failed surgery, right? If you do tendon transfer in the hand and you get adhesion, that's a big clinical problem. So he actually started using video microscopy probably about 25 years ago, and actually visualizing what was going on underneath the skin during surgery. And this is one of the pictures of that. And he actually made this really nice documentary, a couple of them actually, and one of the first ones actually called Strolling Under the Skin. And I think, for me it was an eye-opener, so I would like to share a little piece of that video with you. So this is part of the video that I can really recommend. Now it's available on YouTube. I can actually watch it for free. Take about half an hour.
It was a rubbery elastic system because its role is to avoid reaching a threshold of resistance at which the collagen might shear. It has to allow the tendon to move freely without transferring the movement to the surrounding structures.
So this is basically fascia, what you can see here.
That the biomechanical behavior of this shock-absorbing system could be accounted for by the theory of drawers. As the tendon moves, the first vacuole might undergo traction to a point where it triggers the adjoining vacuole into action. Then the third is triggered, and the fourth, to such an extent that the final vacuole remains almost inactive. Our second hypothesis was that the same process was involved, but that the pressure was distributed equally among the vacuoles. However, this meant we were still only in 2 dimensions, and that our only explanation was based on linear processes. Yet we were sure of something: the tissue continuum, the existence of basic vacuolar-type structures, and the presence of a shock-absorbing system allowing the organs to act independently. We had to move to 3 dimensions to really understand what was happening. And it was around that time that computer-synthesized images came online. They made it possible to visualize structures as a system in perpetual motion with 2 rigid boundaries, a fixed external one and a fully mobile internal one. What we did was to introduce a cross-linking mesh-type architecture which included the microvacuoles on the armature. We then looked for the fractal distribution.
So this is like the tendon, this is the skin, this is what the fascia in between.
The same apparent reality. There really was a sliding system with brilliant liquid lying between the vacuoles and an armature of collagen fibers. This confirmed what we had initially thought about the pulling and tugging going on between the vacuoles. Moreover, thanks to this discovery, we were able to confirm that not only the tendons were able to move independently from each other, entire organs could do likewise, so the system was common to the whole organism. It was then that we realized what we had discovered: this multi-microvacuolar collagen absorbing system.
I think if you examine a patient and you get an eye and a feel for it, I think you can probably understand why some of these, why nerves can get entrapped, and why, for instance, post-surgical scars can actually cause pain. Once you have that understanding, you also might think about the different solutions in order to address those, for instance, the entrapped nerves. Because nerves, when they get entrapped, they cause pain. So this is a recent paper published by Antonio Stecco, who is a physiatrist and the brother of Carla Stecco, and he now works at the New York University School of Medicine as an associate professor. There's a lot of research on fascia. And actually, he, I think, published this review paper where he actually shows what actually going to happen between the superficial fascia and the deep fascia in the skin, where nerves actually pass through. And as you can see, you can have different levels. You can have entrapments of the nerves. And when nerves get entrapped, they get deprived of blood flow because there are small blood vessels that basically supply the nerve of oxygen and glucose. And if that actually gets impaired, that actually causes pain and swelling of the nerves. Another aspect is that when there's pressure on the nerve, and you can all do this test yourself, is that if you overstretch the fascia, you're also going to restrict the blood flow to the nerves. And if you put your wrist like this for half an hour, we're all going to have pain after half an hour because the nerve doesn't get actually supplied with the necessary nutrients. Because it's highly dependent on glucose. Another thing is that obviously there's neural growth factor being pumped from the spinal cord all the way to the end of the nerve that actually maintains the nerves. And if you actually mechanically put pressure on the nerve, you block that, and you get actually more proximally of that entrapment swelling. And that's, for instance, what we see in carpal tunnel syndrome when there is actually when the flexor tendons swell up and actually cause mechanical pressure on the median nerve, which actually causes swelling, and that's basically one of the diagnostic criteria for carpal tunnel. Now, so this what we call chronic constriction injury of nerves has actually been described already in the 1990s and in the 1980s as a cause for neurogenic inflammation and pain. And this is actually a sort of an experimental model where they put a little band across the sciatic nerve in this hind limb of the rat. And actually, you can appreciate that there's actually swelling here more proximally of the constriction. Right, so this is actually sort of an experimental model. You can simulate this neuropathic pain. So I'm not sure if how much training you had in your medical degree on peripheral nerves, but these are all sort of the anatomical fields of the peripheral nerve system. And I didn't learn much about those. Who has ever heard about the posterior femoral cutaneous nerve, right? Two actually important nerves that run superficial and perforate the fascia and run superficial to the sciatic nerve. And they can be easily injured, for instance, when people strain their hamstring. All right, but these nerves are basically everywhere. So, and interestingly, this problem of entrapment of nerves has been described by a French neurologist in 1842, who published a book on nerve entrapments. All right, so we're not talking about new knowledge. This is basically old knowledge, but probably forgotten. And there's actually the French neurologist is Dr. Vailleux. And there's actually if you look in the medical dictionary, what a Vailleux point is, basically it's a nerve entrapment point. So it's an official medical term for a clinical entity that we often overlook. And then this is sort of a way of describing which area, which anatomical field these nerves innervate. And as you can see, some of the areas are really extensive, right? So this is a case I saw back in the Netherlands when I think 2013. There was a girl who was 14 years old and she had sprained her ankle, just a normal sprain. And she had extensive physio and she kept on having pain and limitation in her ankle mobility. And she couldn't hardly load the ankle and she was not able to go back to her sports. So she came to see me, and when I examined her, I sort of think I appreciate sort of the discolorization of the skin, but she had two very prominent nerve entrapment points, tender points over here. Well, basically, I recognized this and actually thought, well, actually we can actually maybe do injection therapy to actually release those nerves, and I used the dextrose for that. And now, at the time I was using a higher dose that I'm using at the moment, but what was really interesting that within like 10 minutes, this girl's pain has settled almost completely, which really created a window of opportunity for her to actually do the proper rehab. And I think 3 weeks later she was back and running. So she had basically a chronic regional pain syndrome because there was actually autonomic dysregulation. And after the injective therapy, we reversed that, and she was very quickly back on track. Now, this is basically sort of the anatomical distribution of those peripheral nerves, the saphenous nerve, the serial nerve, and the peroneal cutaneous nerve, and they're actually sort of drawn onto the skin here. And for instance, I think this is often overlooked as a cause of medial tibial stretch syndrome. So compartment syndrome, deep compartment syndrome. And everyone forgets that actually the pain could actually be caused by the entrapment of these nerves, where they perforate the fascia. But if you look at they've been described by Netter. If you look at the Netter atlas, you can actually see how they sort of located. But realize there's quite some anatomical variation. This is actually a very old sort of image from the 1900s, where they actually show the anatomical variation between people of the trajectory of the sural cutaneous nerve and the lateral cutaneous nerve, for instance. So you can see there's anatomical variation. And so you really have to use your hands to examine the patient to find. And if you what you have to sort of learn yourself is to feel the swelling of the nerve. You can actually look for it, but you have to touch it. You cannot press too hard to feel that. Once you know where they are, and you can actually search for that, and then you can appreciate that they can be swollen and painful. When I was actually in Dubai, I had an interesting case of a 61-year-old male runner, triathlete, who actually always had been very healthy, but in 2012 he was diagnosed with Guillain-Barré syndrome, was admitted to hospital for 3 months. He fully recovered, but then in 2013, when he went back to running, he had developed this chronic pain and tightening of the left calf muscles that actually started during a duathlon race. He was able to finish the race, but he didn't have any real signs of a muscle tear. But despite extensive physiotherapy, he was not able to go back to running. He had some temporary relief from dry needling and foam rolling, but when he was running, basically he had to stop running because his pain level went up to almost 8 out of 10. Further examination, I diagnosed with multiple myofascial trigger points in the midline of the soleus, as well as the lateral gastrocnemius. So I did an ultrasound on his calf muscle, and what I noticed is actually this is the skin. This is the distance, so it's about 2 centimeters deep, and this is basically the myotendinous junction of the gastrocnemius and the soleus muscle. And what you can saw here was actually hyperemic area powered Doppler ultrasound, which looks a bit irregular, sort of. And a bit. This was basically the contralateral side. So which we didn't see. So if you look at the same side, you saw this sort of increased densification of a little bit like a scar tissue, which was hyperemic, and which corresponded with the maximum point of tenderness. I also did some dynamic ultrasounding. So basically, I asked him to plantar flex his foot, and to actually appreciate what was going on with the sliding here. And actually, what you're looking at here is like the fascial structures. And if you do this more often, and maybe this is something we're going to have to pay more attention to also in the radiology practices, because the dynamic study that you can see there is actually, if you compare this to the asymptomatic side, the right side, there's a denser sort of layer of fascia, and well, you can actually see multiple layers here. So it looks like there's actually more sliding going on here on the contralateral side, which was not painful compared to the symptomatic side. So my working diagnosis was that probably had chronic left-sided calf pain caused by medial cutaneous nerve entrapment due to thickened scar tissue of the epineurals of the soleus and the gastrocnemius lateralis muscle. So that's a working diagnosis, because how do you prove that, right? Because it's sort of, you have to sort of look at this for a long time to actually appreciate that there is a difference. There is some new software on them, sort of in research environment, that where they're trying to quantify the sliding behavior, but it's difficult to quantify. It's just more like a qualitative assessment. So obviously, what sort of treatment do we have basically available to us as a sports physician? Well, basically, you can think about injection therapy, trying to actually improve that sliding. And you can use basically PRP, you can use prolotherapy, hypertonic glucose, maybe to stimulate some new collagen formation. You can use cortisone maybe to actually settle the inflammation that you see there. Or you can use isotonic dextrose solution maybe it's a hydrodissection technique to create more space between those layers. So I decided, because it's minimally invasive, to do the latter. But I'll give you a little overview of the comparison of different injection therapies and actually how they potentially can work, and how they can be applied for different sort of clinical entities. So we have the prolotherapy technique, which is basically injecting a hypertonic dextrose solution between 50 and 25% of dextrose. This has actually been described by George Hackett, was a surgeon in the 1950s in the US, who did a lot of prolotherapy research, and he used it actually to strengthen the sacroiliac ligaments in people with chronic lower back pain. And he actually did a case study up to 1,800, I think, patients that he treated with this, trying to actually strengthen the sacroiliac ligaments. It's quite painful, so you actually use an anesthetic with it. So you use a lidocaine, for instance, because the hypertonic glucose really irritates the nerves and can be very painful, or at least for 5 to 10 minutes. And then the idea is that you repeat this every 6 to 12 weeks, because they know from studies in animals that it actually causes a proliferation response and an densification of collagen tissue. And after the injection, basically tell people to be active, but not very vigorous, because you want to actually create a new healing response of the tissue, and you don't want to damage the collagen fibrils too early. Now, I think a more modern version of that prolotherapy is PRP, platelet-rich plasma. And that's basically injecting, well, taking blood from your patient, spinning the blood for 10 minutes, and actually taking the part that actually contains all the platelets, and then you inject that back into the target, the tissue where you expect it to have beneficial effects. There is a difference between leukocyte rich and leukocyte poor PRP. It might have some different applications. We don't, I mean, based on the research, we don't know exactly which clinical problem responds better to the leukocyte rich and poor. But interestingly, they also have an increased dextrose concentration because the anticoagulant is actually contains glucose. So when you actually when you take the blood, you automatically add glucose to the solution. So it raises the question like whether some of the clinical benefits might partly be caused by the dextrose that we're injecting and not just by the growth factor that are in the platelets. You can't, because it's thicker the substance, you have to use a larger bore needle, which is painful. But preferably we don't like to use lignocaine because that might have some toxic effects on the tenocytes or the fibroblasts. And you repeat it every 2 to 6 weeks, depending on which clinical entity you use it for. So there's a lot of debate about it because there have been studies done by randomized controlled trial that didn't show any effect on kidney tendinopathy. But last year, a colleague of ours and James Fitzpatrick, she actually published a study where she uses in people with gluteal tendinopathy and found a positive effect compared to placebo injections. So there is some mixed research results with this. Now, the technique that I use most of the time is actually neuroprolotherapy or perineural injection therapy, which actually been discovered by Dr. John Liftop, who was actually a Dutch doctor who moved in the 70s to New Zealand, to Christchurch, and had a pretty successful MSK practice over there. And now he's traveling around the world. He's now in his 70s and teaching other doctors about this technique. And he actually discovered that the effect that he saw with the prolotherapy was also, very similar effects when he was using isotonic 5% dextrose solutions. But he had to buffer them. So you have to bring the pH to a pH of 7.4. So you don't want to irritate the nerve. And the goal is actually to treat nerve pain. And he discovered that actually if you inject 5% dextrose around nerves, that actually had immediate pain reducing effect. It's often used in combination with fascial manipulations or soft tissue therapy. Use a very small bore needle, 30 gauge, so it's like the same needle that physios use for dry needling. Don't need any sedation, no anesthetics needed, and you can actually do this every week if you want to. And the good thing is that you can actually you can really speed up the rehab and then get people back to an active lifestyle or even back to their sports. And then we have the cortisone, which I think is still considered to be the state of the art and very often used in both sports medicine practices as well as in radiology practices, where you actually use kenacort or triamcinolone to actually reduce the inflammation. All right. Hardly ever used in combination with soft tissue therapy, as far as I know. Use a larger bore needle. You mix it with anesthetic because it gives you some burning sensation as well. And you can do this every 12 to 24 weeks. And you combine it with gentle activity because you don't want to flare up the nerves. The problem is that this is catabolic, while this is actually anabolic. So this means that actually you stop, the side effect of cortisone is actually stop protein synthesis. It stops inflammation, but also stops protein synthesis. While if you're trying to actually make tissue stronger, you want to have an anabolic effect, and that's actually what the prolotherapy and the PRP does. And I think this is more neutral, so this doesn't have any, as far as we know, anabolic or catabolic effects. So what happened to my patient that I saw? So we did an ultrasound-guided perineural injection therapy. So I targeted the denser tissue over here. Also the fascia, so trying to actually go in between the fascial layers and create space between the layers. And interestingly, so I used in total 8 injections of 2 mils, 5% dextrose. And interestingly, 5 minutes after the injection therapy, the areas that he injected was completely pain-free, and I didn't use any anesthetic, right? So 2 days after the injection therapy, he had zero pain on walking, and then we built up basically with running. And 3 weeks later, he was back to full training running and was able to run basically half a marathon without any problem. So as an example, and I can give you many of those, that's sometimes if you recognize what the problem could be, can be the benefit of just simple, isotonic dextrose solutions. Okay. So what is the current evidence for this? Because I get this question all the time, and I mean it's limited. I have to admit that. But there are some actually studies now that showed in a well-controlled design that it works for lower back pain. And it works also better than triamcinolone, so cortisone injections for carpal tunnel syndrome patients. And this published last year in Annals of Neurology. Really well performed study, and I'll show you the data later on. As well as better than basically a placebo injection. Right. So the idea or the rationale is that this dextrose has a direct or indirect analgesic effect on the TRPV1 receptor. This is basically a capsaicin receptor. So there are like 26 different transmembrane receptor potential receptors. Only this one is only discovered in 1997. So a lot of medical doctors haven't never heard about it in medical training. I hadn't at least. But this is basically a capsaicin receptor. So and we know from studies where you put capsaicin on people's tongue, in a double-blind fashion, you can actually neutralize the effect of capsaicin within 30 seconds using dextrose. All right. So there's either sort of a direct or indirect effect on this receptor. There's been studied actually, Petri studies that show that it reduces immunogenic inflammation. It may also have some osmotic effect on the collagen matrix and the web. And I think about that spider web that we showed you in the video of Dr. Gimberto. And probably can also reduce the adhesions and the chronic nerve compression injury in this spider web. So it could have multiple actions depending on how we apply it. Now, another interesting paper is that actually looked at the effect of glucose in chondrocytes in a basically in vitro study, and they found that aggrecan, which is actually the it's a molecule that binds water in the cartilage, that got actually upregulated if you if you expose chondrocytes to glucose, and through this specific pathway. And when I showed this actually to one of my colleagues, Dr. Steve Rutsky, said, "Oh, that's interesting." He said, "That pathway is really important because that's actually important. That's been shown to play an important role in neurogenic inflammation." So I actually did some research and discovered that they actually, in 2007, they published this paper, which is really a nice study where they looked at how this microRNA influences basically chronic inflammatory pain by downregulating this high mobility gene box high mobility gene box 1 in both in in vitro and in vivo studies. So there was a rat study as well in in vitro. So what actually, if you combine this information, so if glucose causes upregulation of that, basically, then basically you can actually influence chronic inflammatory pain. I mean, this is a direct pathway, and it works through this gene. All right. So this doesn't explain the acute pain-reducing effects of glucose, but it may actually explain why you get a secondary healing response and a reduction of chronic inflammatory pain. So, but I think there's more research need to be done to get a better understanding of how dextrose can have an effect on nerve pain. But if you inject it around the spinal cord using a caudal epidural technique, it also has been shown to have an acute pain-reducing effect. So if you look at the other nerve structures, spinal cord, that's actually shown over here. So you have this was a placebo-controlled study where they actually injected using a caudal epidural technique, and you can see that after 15 minutes, compared to saline, you see actually a pain-reducing effect from just dextrose that lasted up to 2 weeks, right? The same group actually published a study last year where they repeated this 3-4 times in the patient with chronic lower back pain. I found that after 4 sessions of this, the pain-reducing effect lasted up to 1 year. So you have potentially an interesting application for people with spinal canal stenosis that don't respond to corticosteroids, for instance. Now, this is a study where they use it in carpal tunnel. So this is really published in Mayo Clinical Proceedings, where they looked at 3 primary outcome measures. Basically, the Boston carpal tunnel questionnaire. They looked at median nerve cross-sectional area, and they also looked at nerve conduction velocity. And what it actually shows, after a single injection of 5 mils of 5% dextrose, you see that after 1 month, 3 months, and 6 months, you see that their pain score improves. You can see that their median nerve swelling actually normalizes. And you also can see that their nerve conduction velocity normalizes, which doesn't happen in the group that, the control group. I mean, not significantly. Saline. They injected saline. So one of the ideas is that you can use saline actually and use a high dissection technique to free up the space around the median nerve, and that might have some potential benefit as well. And maybe you see a little bit happening, but the dextrose is definitely superior to just basically saline. Then they repeated the study, and this published in Annals of Neurology, and this is really a high impact clinical journal with an impact factor more than 10. And they compared it to triamcinolone, which is basically our current standard treatment for carpal tunnel syndrome patients, right? And basically they find exactly the same effect. So they repeated basically the clinical effects on both pain score, the nerve conduction velocity score, as well as the median nerve cross-sectional area. So they find an effect from the cortisone, the steroid, but that actually wears off after 3 months. So after this was like a 6-month follow-up period. So you see that after 3 months, the dextrose group keeps on improving, while after the cortisone group is sort of back to baseline almost after 6 months. And that's obviously what we see a lot in clinical practice, that people who have any response, but it sort of comes back, and then they're sent to the hand surgeon for carpal tunnel release. So I think about this study. This is like a really high quality research where they found a very strong clinical effect, and confirmed in 2 independent studies, 2 different populations. Now, if you look at the study, you can say, well, that's nice for carpal tunnel. But remember, the nerve doesn't know where it sits, right? Well, it sits in the carpal tunnel, in the tarsal tunnel, around your shoulder, around the fascia. It's the same tissue. So if it works in decreasing the swelling after single injection in the carpal tunnel, it's going to work basically everywhere. And that's basically my clinical experience, that if you inject around any sort of nerve that might be swollen and painful, although you may not be able to visualize that on ultrasound, it actually has, it should have a similar effect. Okay. Now, when I was working in Dubai, all the patients need to have a baseline VAS score, a numeric rating of the pain score, on a scale from 0 to 10. And after 2, and it's by law, if you work in Dubai, all the patients that get injection therapy need to have a phone call from the nurse to ask the pain score after 2 days, 10 days, and 6 weeks. That's mandatory. If you get a clinical audit, you got a big fine if you don't have it. So we had a very good data set. And we actually, these are the regions of the areas of patients, the number of patients that I treated for head, neck, shoulder pain, elbow, forearm pain, lower back, coccyx, buttock and groin, hip, thigh, hamstring. So I've sort of grouped them by body region, knee, and the lower ankle and foot. And these are the number of positive responses after 6 weeks. All right. So a pretty high number, varying between, like, say, 67% and about 100% in this group. If you look at the pain score, this was the whole group together, so 37 cases. And the average pain score at baseline was 7.1. After 2 days, it was 3.5. And after 10 days, it was 2.1. And after 6 weeks, it was 2.2. Now, the 30 of the 37 had actually a durable response after 6 weeks, and you see the same pattern here. So it's the effect that's a bit stronger if you exclude the non-responders. But I think 80%, 30 out of 37, 80% is a pretty good number if you look at a lower or minimally invasive technique where without any major side effects, except maybe some bruising. Now, if you want to summarize this for yourself, I think if you talk about peritoneal injection therapy, neuroprolotherapy, or prolotherapy, be aware there are that you have to differentiate between the high and the low concentration dextrose. Right? Also, remember that if patients have a flare-up after even using isotonic, it could be caused because it's not buffered. So if you inject an acidic solution on the nerve starts flaring up. So buffering is really essential. I think it's a safe and low invasive treatment, and if you're not sure, sometimes it's worth trying. Yeah? So it's almost like a diagnostic procedure. Like, is this a true nerve pain or is it something else? Is there something else going on? And then you can use it because it's superficial and see what's happening. People respond within 2 or 3 minutes, and actually it's probably an untapped nerve. There is some level 1 and level 2 evidence for this treatment, and I think we can wait for. I think we should do more research in this area, although it's very difficult to get people get funders for this. But probably it's safe to try if you really inform your patients and your athletes what the pros and the cons are. I think it may reduce pain sensitization and speed up rehabilitation. And I think it's definitely a safe and more effective alternative for corticosteroid injection in the carpal tunnel population, syndrome patients. So think about it when you have someone with this problem. I think that's my practical experience, that once you have settled the nerve pain, it's going to be easier for the soft tissue therapists or the physiotherapists to actually work on the fascia and improve the gliding again. So my experience is that if you do only injection and you don't do the soft tissue work afterwards, your results won't be as good as when actually you combine it. So I really like to work together with physios and soft tissue therapists, and a number of you in the room, because it works synergistically. So it should be part of a comprehensive treatment plan, a rehab plan, to speed up basically return to sport or return to work. And there are a few patients that actually have had a temporary pain response to this. So these are the patients that say, "Oh, initially great, after 4 hours, when I got home, I got this tremendous flare-up, and it lasts for 2 days." And actually, I started looking into it a bit more, and it looks like there are the patients that have a hypermobility syndrome or a mast cell activation disorder. And a mast cell activation disorder is basically are the mast cells that are contain the histamine that lie in the connective tissue. And once you inject in that area, they can be activated. And those are the people, clinically at least, that start recognizing them better now, that actually are easily overstretching their fascia, right? Because they're hypermobile, so the connective tissue is more flexible. So they overstretch their nerves more easily and can actually cause nerve pain. But also, if they, for instance, someone who gets bitten by an insect and gets this massive hives, right? You have to take an antihistamine for that. Those are the ones that seem to be more prone for this. So what I actually do is, if these people have these responses, I say, well, let's repeat the treatment, but do it under protection of montelukast, which is a mast cell stabilizer, and an antihistamine. And clinically, at least, I don't have big experience of that. It seems like that actually takes that secondary pain response away. So think about that when people have that come to you and say, well, I went to see the sport physician who did this prolotherapy, but initially it seemed to work, but then I got this secondary pain, so I'm not going to go back. All right? This could be this category of patients. If you think a patient is potential candidate for this, on my webpage have some information on neuroprolotherapy, give you some background information with references, etc. So people, I think, especially in Canberra, they like to be educated and like to know what's going on. So I give that's a good starting point to refer patients to get some good information on how this can help, potentially can help, and for what sort of clinical problems we use it. So yeah, I'd like to finish my presentation over here, and I'm happy to answer questions in the panel discussion. So enjoy your food, and happy to discuss it further with you. Thank you.